Welcome back to Health Policy Off Script. We are at the end of our first season, and we thought it would be a great opportunity to sit down with the three hosts and talk about the process, the results, and their feelings.
But before we get to that, the wait for season 2 won't be a long one. Many guests have already been confirmed, and recording sessions have been booked. I am Matthew Hart from Longwoods. Let's get into it. Ivy, how'd it go?
Yeah, I think our objectives was to change the conversation and to move people into action. And that was what we were hoping to do, and to have those crucial conversations that would lead people into action. And I think that we have instigated, I think, a fire in the belly of folks to say, yeah, we have to move. We've done that so far.
Stephen, you've been known as a bit of a pundit, a blanking on the right word here, but you've been able to put provocateur. There we go. That's it. Do you think you've learned anything? Do you think you've been able to get people to take that step that you want them to take?
I'd say we're partway there. We, as Ivy said, we wanted to change the conversation. I think the reason we started this is because it's been very difficult to change the conversation.
Mm-hmm.
And the parts that make me guardedly optimistic to set up season 2, I was pleased that there wasn't much talk about structure and restructuring and fine tuning, and that there is if you do this and this and this, things will get better. People talked a lot about leadership and courage, and we don't actually need a lot more evidence in a lot of areas to do something. So I think the conversation is broadening out and is more explicitly political, which in my view is helpful because it's so true. We didn't quite get the full account of how the sausage is made as I think we were hoping for, like exactly what happens around the senior executive table or the cabinet table that makes it so hard to do, quote unquote, the right thing, even when there's consensus about what the right thing might look like.
Dale, in your experience, you have been more than a fly on a wall. You've been right down in the trenches. What did you think of the first season?
I think I've learned a lot, and it's been great to bring in people with so many different perspectives. And we're starting to get there in the objective of speaking the unspoken. And I myself, even having been a participant at many tables, still don't feel that I've got the whole picture about how decision making is made, who does what, how are they influenced, who comes in at the last minute and changes the whole game, and what are the various component parts that we can change, what are the various component parts that are quite sticky and need some real retweaking. And I think we're getting there, but I think that's something that we need to really push next season.
Can I interject here? Because I want to say, I don't know that we need to know how the sausage is made per se. I think that we need to know enough about that to know how to change the sausage, how the sausage is made. So, for example, someone who comes in at the last minute, why does that change things? How, like, why? And it comes back to our theme of accountability. Why do we allow that to happen? Or why is that allowed to happen from a system perspective?
I don't think I'm disagreeing with you, but I might be. Um, I think we know we have the research-based evidence about the things we typically collect evidence about. So,
Yeah.
for example, we know that done well, home care is cost effective. But what we don't know is, why is it that the decision-making process discounts that? Where the conversation needs to head is, what do the public really worry about? Well, they don't worry about preventive care. They don't worry about 10 years down the road. They worry about clogged emergency rooms and the unavailability of a specialist appointment. That makes sense. Like the public is not irrational in that sense. but other countries manage to do things that we don't do. I think the question is this just a failure of communication, as Cool Hand Luke would say? In other words, since policymakers, and maybe I'm being optimistic here, they understand exactly where this equation isn't turning out particularly well, that we probably don't get great value at the margins in the downstream part of the system. We have a lot of avoidable health spending that we don't avoid. And as we did in the 80s, even, there was a time when we invested more in community and took population health more seriously. So, is there some way to get that back? And why is it that all of that is lost in the public discourse? And I think the question that raises is there something changing in the political culture that makes solidarity weaker?
All of those things are true, but I think that what the critical issue is, and then coming their communication and the grand aspirations, is that we're not communicating it anymore in the sense that what is the vision for healthcare in the provinces across Canada? This theme has come up time and time again across almost every episode. What are the goals? What are people accountable for? What are we trying to achieve? And I think you could ask anybody on the street or anybody who works in healthcare, what is the goal of the healthcare system? What are we trying to achieve? And we would not be singing from the same song sheet.
I mean, Arthur spoke about that in terms of planning. Planning should be done in the back rooms. It should be boring work. It should be work that the system does that we aren't necessarily communicating about. But it just seems that the policy is focused on very reactive, very immediate concerns rather than a more system focused approach to be preventive and to be upstream and to be solidaristic, all of those positive dimensions.
So, why do you think that is?
Well, like what is happening at the decision-making tables? What moves people at decision-making tables? Because I don't think that it's evidence. It might be, but I think evidence is, oh, could we get some evidence to support where we want to go, right? It's a little bit more icing on the cake rather than cake. I'd like to really appreciate sort of the politics of health policy. And so I think, having those conversations, I think would be important.
The evidence is
They have some evidence.
it takes a year and a half to see a gastroenterologist, and it takes 12 hours to get triaged through the ER. That's the evidence that they see in front of their faces.
Yes.
And that's what they think they have to react to.
Yeah.
I don't think there is anybody thinking a whole lot about the grand vision the way they used to in the 1980s. I think the country is a harsher place than it used to be.
Well, and something that we haven't looked at in any of our episodes is how the media brings certain issues to the public attention. What role do they play in focusing just on downstream? I suspect it would be very difficult for someone to do, a series that focuses upstream. And I think that what is moving people is more reactive stuff, both the public, both the media, and then politicians sort of follow suit.
Right. But sure, you need to focus on the upstream, and I think we all agree on that.
Yeah.
But we're not getting the downstream right either.
No.
Yeah, it absolutely is reactive. But what are the marching orders for the ministers and the deputies? I mean, we heard from Kelly Lamrock that when he started as minister, this first briefing note were his talking points, and not here are the objectives and goals that we have set for ourselves in this sector, this sector, and this sector. Here's what you have to do. Go do it. And is that happening still? Or is there general guidance, but that can get derailed by the whim of a minister or the whim of a premier?
One thing I did learn is that you need to be have a finance or economics background to work in the Treasury Department.
Well,
Brought this up in our pre meeting about this podcast. Is so Danielle Martin is a family doc from Ontario and just recently elected to the federal government. She is now a member of parliament and she is on a standing committee on finance. She is on a standing committee of government operations and estimates. Nothing she is doing with the federal government has anything to do with healthcare, which brings up the question for me, are the right people in the right places?
So to suggest perhaps, Matt, that maybe we don't need someone with healthcare background to be the minister, as long as they are excellent leaders and can understand their field. Maybe, maybe not. I think we've had excellent leaders who have had healthcare backgrounds and have not.
Can I raise one like really sore point that I have that we always let the federal government off. It operates the fifth largest health system. Of course, we need to have a minister of health who has some expertise in this area because they operate a health system. Do they have to be a health professional? Not necessarily, but they should have some health knowledge. I mean, even looking to the United States, their Veterans Administration system is one of the most high impact. It's an excellent system within the context of the United States. There are more excellent systems in the United States, but the VA shines. Our Canadian Armed Forces, Indigenous Services Canada, Corrections Canada, RCMP, and the health systems that the federal government operates are not the excellent systems. Why do we never hold them account? There are never questions asked about the federal health systems in federal leadership debates. And whenever healthcare is talked about, it's the federal government's role in transferring payments to the provinces. Now, so I just want to present a counterpoint that I think it would be excellent. And if we want to talk about ministers of health, when Jane Philpott was there, I think she was really doing some excellent work. She shifted over to Indigenous Services Canada, which is a health system that the federal government operates, trying to do that work there. I mean, for political reasons, she didn't continue, which is unfortunate. But I think that our absence of discussion about federal health systems lets them off the hook. And then the lie gets regurgitated over and over again, even on my favorite CBC, where they say healthcare is a jurisdiction of the provinces. That is not true. It's shared between the federal, provincial, territorial governments, and municipal governments. A lot of what happens in terms of social determinants of health is at a municipal level. So anyway, that's my little rant about the system. You asked me to rant, and that's my rant.
Right. So the federal government should be setting an example with
Yes.
Indigenous health, with the armed forces,
Absolutely.
and hitting it out of the park and putting the provinces to shame, and they're not.
No.
Pardon me. I don't think this is helpful. First of all, the federal government and Indigenous health services, beginning in the 80s, devolved it. That was the whole point, with the active lobbying by Indigenous communities. So it said, look, you can't run anything. You're ham-handed, you're ham-fisted, you're insensitive. We will run it. And the Fed said, fine. So the feds don't run Indigenous health any more than the provinces run their healthcare systems. They fund them, they ride herd on them. There is some general vague accountability, but basically everybody does the same thing. You pour a bunch of money in and hope it works out. So I'm going to say the Constitution does make it primarily a provincial responsibility. This is an infrastructure government that we have. What is the infrastructure missing in healthcare? We don't have a national health human resource strategy, and we have all sorts of absurd barriers and complexity in regulation, licensure, mobility, and everything else. We don't have in 2026 a functional health information system at all. People should be able to get real-time performance data that would inform what they do. And these are expensive things. They're important things. And where I would give the feds terrible marks, if you're going to have pan-Canadian health organizations, why do you set them up to fail, either through underfunding or complete negligence and oversight, as with Canada Health Infoway? So go ahead, Matt.
I wanted to kind of stop you guys there, because what I want to talk about is, how do we make change, and how do we get our guests to talk about making change? How do we influence the system as people of influence? All three of you are people of influence. All three of you are people in the public. So how does the public make change? How do the people who have influence make change?
I think the best that we can hope for is that the podcast changes people's perceptions of what the problem is. If you look at the Arab Spring, if you look at Hungary in 1956, why did people finally say we're going to rise up? This is not acceptable anymore. It wasn't because they had new information. It's because they said, all right, I'm not going to put up with this anymore, and it's time to act. The system is so complicated and has so much hardwired tradition that what will change it is some movement that suggests this is unacceptable. It is unacceptable that we're spending $400 billion and can't give everybody primary care. It is unacceptable that I have to wait 18 months to see a specialist. I mean, people grumble about it. People wring their hands and say this is terrible. And some people are leaking to the private system, but there isn't that sense that we're mad as hell and we're not going to take it anymore. And I think similarly, and to your point, there have to be leaders who say this and say, look, I'm a leader in this system. I run a big hospital or a health authority or something. And I'm telling you, the fundamental problem is not money. The fundamental problem is that, for example, I can't manage anything. There's way too much autonomy in the system. Or we are deliberately not accountable in any way, and we don't get information that actually says we are or are not achieving objectives because they're not particularly precise. So it's the dissatisfaction with the status quo and understanding that the problem, it is not fundamentally about scarcity. Now, that's a very difficult argument to make to a public conditioned that it's all about scarcity, but somebody has to make it. And we can make it. Our guests can make it. I mean, Kelly Lamrock laid this whole thing out in his reports. They're crystal clear on what the problem is, and they're bold and they're brave. It'll be a litmus test if anything happens in New Brunswick that's different because he's kind of a unicorn. I mean, there are very few people, and he shared it with us, very people that articulate, that experience. They've seen it as a minister. They're now an advocate. He's a lawyer, and he's an incredibly good communicator. Well, if we had 1,000 Kelly Lamrocks, would that change the system? I think that's the question. But there aren't 1,000. Are there 10? We don't know.
Right. But picking up on the question of leadership, and we mentioned in an earlier podcast that we need to move past, change management 101. And leaders today need to operate in an entirely different way than they have in the past. We talk about complex adaptive systems and whatever name you want to give to that. There's a lot of moving parts. And the leaders now have to actually work on that precipice between order and chaos. And it's right in that sweet spot where the innovation takes place. And they need to be comfortable with discomfort in the way in which they manage. They also need to be comfortable about divesting some autonomy to empower the people around them. And they have to be able to communicate in a way that gets everybody on the same page, coming back to the point I was making earlier about what is it we're trying to achieve? And being comfortable with the goalpost shifting, being comfortable with perhaps things not coming tied up in a nice little bow all the time, and not focusing on the problem, but what they're trying to achieve. Everything in our system works against what we need in leaders.
I think I want to pick up again on the issue of accountability. And I think Janet Davidson highlighted that. We talked a lot about that in her episode. And how is it that we create data systems that transform data into information and actionable information that is easily digestible by the public? The public can understand that. The public can be part of that accountability system. And, this kind of loop in terms of leadership, public accountability, and data and information in order for that to move the system forward. How the public, sort of not so much the public accountability, but how Tommy Douglas was able to communicate to the broader public about what it is that they were trying to achieve in getting Medicare here in the first place. And and that was based on no evidence whatsoever, other than, there were other health systems worldwide that they were able to cover that, and it spoke to people's hearts. So how do we get that balance of speaking to what, people feel strongly about? And I acknowledge, Stephen, what you're saying is the public is a different public than it was in 1962 or 1970 when we were trying to make these changes. But there are examples of leaders who are able to get into the public zeitgeist about something and are able, through leadership and through accountability, to kind of move the needle forward.
Well, but I think you hit the nail on the head, and we talked about this as an overarching theme is accountability. So we talked to Colleen Flood, right, who is brilliant. She understands the law, she understands the politics, and we talked about these ringing, glowing principles in the Canada Health Act, comprehensiveness and accessibility being the two most substantive ones, that they're violated every day, like enormously. And she has mused, as have I, as an amateur, about was it going to take a class action suit? Like when those words mean nothing, when they're almost cynical, they're almost satirical to say, oh, yeah, we have a comprehensive and accessible system because the Canada Health Act says we do. Well, like hell we do. It's not, it's the least comprehensive in all the rich countries. So the question is, and remember we asked the question, I believe we asked it to Janet. So Janet, what happens at the cabinet table when you see these enormous variations in wait times? Not just the fact that some people wait an unconscionable length of time, but at the same time, a whole bunch of people hardly wait at all. In fact, the norm is not so terrible. It's the outliers that are terrible. What happens? And even she didn't know, right? So how is it? I mean,
That's my
and the pub,
question. Why is that happening? Like, why is that
well,
happening?
and so we keep talking about governments and so on, but my question is, so I'm the orthopedic surgeons in my city, and I see the wait time variations that some people wait 6 weeks and some people wait a year and a half for a hip or a knee or something. What is their collective response to this, and why don't they seem to have one? Like, yeah, it's great. I don't care where the leadership comes from, but why isn't somebody standing up and saying, look, we as surgeons, we have to do something different here. The way wait times or wait lists are organized, the way wait time or OR time is allocated, this is not serving the public. Well, I think what happens is those who stick their heads up on these issues tend to be vilified by some of their colleagues because there is money, status, all these things are on the line. And I think one of the things that we need to figure out, or someone needs to figure out, is how do you restore a leadership role to people who have the title of clinical leaders to be accountable for some of these things? And you say, look, you people, you surgeons or whatever, we're not telling you how to do this, but it is your responsibility to compress these wait times, this variation. And we will help you to do it. But at some point, it's not all carrot, that there has to be some stick here. And that's part of a combination of leadership and accountability combined with management. So you need to do both, right? And it's
And
not
management not being micromanagement in the middle, right? But management in terms of performance expectations on
exactly.
outcomes.
Like everybody else in the world has, right? You know, you have objectives. You sit down once a year with somebody and you're evaluated your performance and you met these targets and not, and here's what you're going to work on. Well, nobody does that.
Well, and expectations about sort of how a system is integrated. When Quam talked about how when he was in the UK, there were specific spots marked for referrals. It wasn't this kind of opaque negotiations in terms of where do you go to in terms of getting a referral, and a comprehensive system that includes mental health. I mean, nowhere is it perfect around mental health services and how comprehensive we cover that. We recognize that there's stigma, but that's an area where really we could benefit. That is where sort of the hearts and minds are of the
Okay.
public is in regards to
Ivy,
mental
just
health
be
services.
clear. We suck. Honestly, right?
No, we
Mental
do.
health addiction, like
Yeah, no, we absolutely do.
Where does it start? Does it start with the feds? Does it start with the provinces? Does it start with the associations, the colleges? Where does it start?
I think one of the things that I learned from a colleague a little while back who was trying to make change in a particular region. And the point this was related to kind of integrating primary care services kind of in a geographic area is that you start at the top and you start at the bottom.
Mm,
And you need to start with the level of governance and getting people on board, but then you have to have the front line and say, have at it, and really listen to the front line about what that's going to look like. So it's got to be both. So yes, absolutely, the feds in the provinces have to get their acts together. But there is so much untapped potential at the front line.
Let's kind of bring us back around to the objective of the podcast. How are we going to ensure that we influence people, provoke people, give them tools so that we can meet our objective of providing information and getting people to make change?
If we think that the diagnosis of the problems is at least partially inaccurate, if we want to open up people's minds to the notion that it's not all about scarcity, it's not all about money. There are a whole bunch of things here like clinical autonomy, division of labor, and accountability that need to come in. We need to really, we need to really push our guests on this and say, so look, how would you change that? The reality is, if we don't solve the access problem, people will not have time to think about anything else, and I don't
yeah.
blame them. So I think focusing on at least some episodes in season 2 on really getting that thing put to bed. Like, what is the solution to this access problem? And please don't tell us it's another $200 billion. And find out what the prospects are and who should be responsible for fixing that. Because I'm a little less, my heart doesn't flutter quite as much when I think about how the front line people are going to solve this, because a lot of those people are pushing the scarcity narrative. And please give us more money. And if there were only more of us, doctors, nurses, whatever,
I
then
disagree, Stephen, on
that will
that.
fix this.
It's the front line that are actually solving the problem oftentimes, but they're little microcosms, and that's not being spread. So there's so many examples where primary care on the ground has taken the bull by the horns and opened some kind of a service to their entire community. There are ways in which finally, services have realized that it's the administrative assistants who can figure out how to stop that bottleneck in terms of wait times and getting timely access.
So what's not, why aren't they doing it now in at scale? I agree. I don't think there are a lot of problems
We are a
that
country of
prevent.
pilot studies and pockets of innovation that don't get
Yes.
spread and scaled. So that's what we are that's the nut that we're trying to crack here. And I think that when we talk about is access the issue, access to whom and for whom, because I think that we need to expand that. Walter talked about if we have an integrated system, there's a variety of different types of practitioners and services that one needs to have access to. If we're always focusing downstream, and we're just focusing on access, to physician and specialist services and hospitals and hospital wait times. And I appreciate that we often get pulled into those conversations because that's where the data are collected. That's where the media produce reports. That's where, advocacy focuses on, and that's what the public hears. And I'd like the public to hear something different in this podcast. And we ask everybody for solutions. What would make things different? So I think we need to have a broader frame of reference and what are we talking about in terms of access, integration, inclusive of mental health, Absolutely. So I think it's an issue, but how is it that we're really focusing on access?
So we're gonna wrap up here in a minute. So a couple quick things. So silence is a choice. We've discussed that. All right. That is your choice to be silent. Um, if you want to speak up, it's going to cost you something, but keeping silent again is going to maybe cost you more. So my final kind of question to you is, who do we need to have on this show? Are there specific people? Are there specific types of people? Who needs to come out and talk? And who do you think would be willing to talk? What type of person would you be willing to have these conversations with?
Well, I'd love to have a conversation with a probably former head of a medical association, because again, the extraordinary power of the profession and those agreements, I think, explains a lot of the problem. And I think the more we can focus in season 2 on, can that thing be solved? It will move the conversation forward better.
Right. And I think we also need to talk to people who are CEOs, deputy ministers, assistant deputy ministers, because sometimes the minister lives in a little bit of rarefied air. And if we want to know what's actually happening when the policy's been defined, but the people who are doing the busy work trying to really flesh it out, and also understand where the barriers are and what they're bumping up against, kind of the political pressure on top, and then kind of reality on the ground, and help us understand what that looks like and what's needed to get it unstuck.
I want to pick up on the theme of silence, and silence is a choice for those who have vested interests and who seem to be doing fine in the system. So I think that we want to find out where those silences are, that they're just going to let the system run its course and they will continue to, benefit from it despite the dysfunction for the public.
So I think we've set some clear examples and some clear objectives for season 2. I mentioned earlier in an email to the three of you that I feel like I'm taking a crash course in poli-sci. Season 2, I am really looking forward to receiving my master's. So thank you very much.